Thank you all so much for coming tonight. I've put together this talk to share what I hope is the best and most informed information for you on the field of palliative care and what we can provide to whether it be your loved ones or yourself, or just if you're curious, from my colleagues, from my mentors, people like Diane Meyer, Stephen Panelat, Thomas Strauss here at UCLA. And I hope I've been able to put that information in a way that is most helpful to you all. So first, I just want to review a little the overall goals that we're going to hope by the end of this that you know what palliative care is, and to know what common issues that palliative care can help to address, and to know when someone should ask for palliative care. So first I want to start by asking you all, and I may do a little bit of participatory questions. If you don't answer, that's okay. But if you do, I'd appreciate it. First, if you could raise your hand if you're here simply because you're curious about palliative care. Great. And who's here for a loved one to learn about palliative care? Wonderful. And anyone here for themselves? Great. And one last question is, who already knows, is somewhat knowledgeable or knowledgeable about palliative care? Okay, so maybe about a fifth of the audience here. So that's the consumer awareness. It's not all that unrepresentative of what we have in the United States. Most people just don't know what this field is, so I'm really glad you're here tonight to learn more. So this was studied in a public survey in 2011. How knowledgeable, if at all, are you about palliative care was the question. And 70% of people, about 3/4 of people, said they just don't know. And a very small percent, about 8% of people, were either knowledgeable or very knowledgeable about what it is. So you're quite representative of the population in the United States. I want to first just talk a little bit about and ask a little bit about suffering, because it's such a central tenet of what we do in palliative care. We're tending to suffering, we're relieving suffering. This is a lot of what we're aiming to help people with. Does anybody feel comfortable enough to volunteer? How might they define suffering or describe suffering?
Pain.
Say again? Pain.
Not only the physical pain, but depression, psychic pain, fear of dying, fear of family, all.
Fear, the non-physical symptoms, the psychological. Thank you. Anybody else?
It's without relief, the pain, that's the real suffering.
Suffering's pain without relief.
Yes.
Or maybe the psychological distress or the family distress without relief. Great. Thank you. And here's some kind of other words to add to that, maybe from a Judeo-Christian point of view, as a means to experience doubt and rediscover faith, or facing the reality of human experience. Or maybe from a Buddhist background, looking at suffering as impermanence and as a central tenet of Buddhism, of attending to and relieving suffering. So I want to go to a definition from a physician and author, Eric Cassell, who's seen as one of the founders of palliative care. Suffering occurs when an impending destruction of the person is perceived. It continues until the threat of disintegration has passed, or until the integrity of the person can be restored in some other manner. It follows then that although it often occurs in the presence of acute pain, shortness of breath, or other bodily symptoms, suffering extends beyond the physical, just as you had stated. Most generally, suffering can be defined as the state of severe distress associated with events that threaten the intactness of person. And some of you may or may not be familiar with Cicely Saunders, a nurse, social worker, and then physician from the mid-1900s who developed essentially the field of hospice in the Western world out of Britain. And a lot of the concepts she developed became part of the field of palliative care. And one of those really important ones was total pain. So a lot of how you all had answered is pain is physical, and it's that physical that hasn't been relieved, that hasn't possibly been tended to or successfully relieved. The emotional and the spiritual side. So a simple definition of palliative care being from Diane Meyer in the Center to Advance Palliative Care, that palliative care is about matching treatment to patient goals. Something you might think, don't we always do that? Yes, and sometimes it's more complex, but sometimes it's simpler. We always want to be matching matching treatment to patients' goals. Sometimes it may be, for example, I saw a man in clinic in my residency program who simply did not want to take a statin for his high blood pressure or for his high cholesterol. He knew it could help him live longer, but for him, about his goals and the values to him were about natural medicines, about taking things in a way that weren't part of our Western medicine culture. So he was not willing to take the statins we had, despite knowing it would likely prolong his life. After prolonged talks and figuring out what really kind of made him tick and what mattered to him, decided that the parts of a statin, the red rice yeast, was what he felt would be in line with his value system, and we were able to find a treatment that matched his goals. So I know for me, at least starting in my training, I was starting to do palliative care then without even really knowing it. So let me go through a longer definition of palliative, and we're going to break this down and go through the key points to help you understand all the pieces here. So from the Center to Advance Palliative Care, that palliative care and the medical subspecialty of palliative medicine is specialized medical care for people living with serious illness. It's focused on providing relief from the symptoms and stress of a serious illness. The goal is to improve quality of life for both the patient and the family. Palliative care is provided by a team of palliative care doctors, nurses, social workers, and others who work together with the patient's other doctors to provide an extra layer of support. It is appropriate at any age and at any stage in a serious illness and can be provided along with curative therapy. So let's kind of go to these kind of highlighted parts here. So serious illness. So serious illness is heart disease, it's cancer, it's dementia. These are serious illnesses. And it's about relief from the symptoms and stress of a serious illness. Anyone that has had a loved one or themselves has been through a serious illness knows that it's really difficult. There's pain, there's nausea, there's many different symptoms that arise, and palliative care is about providing that relief from these symptoms and that stress. And fundamentally, it's about improving quality of life. So we heard this in the introduction, that it's about improving the quality of life for both the patient and the family. And that's really a core tenet of what we want. We want to help people improve quality of life. And it's provided by a team. So it's not just one person. It's many people working together to address the physical, the psychosocial, the spiritual aspects. And we'll talk a little bit about how do we achieve that in our health system. How do we get that team put together? And it's an extra layer of support. Anyone with serious illness is seeing their primary care doctor, seeing their oncologist, and knowing that they have their family as a layer of support. This is another layer of support. Palliative care is there as that layer. And it's at any stage. So it's not just for people who are dying. It's also for people who are at the end of life. But it's for people at any stage of illness, along with curative therapies, to help people tolerate those and do better. And we're going to talk a little later about some of the evidence behind what happens when we're involved and can help along with curative therapies. So what is an interdisciplinary team? So we had mentioned the physician, the nurse, social worker, chaplain, and on our inpatient palliative care team in the hospital, that's our general makeup. But we have access to people that may not be specifically on a palliative care team, but we're all working together with the physical therapist, the occupational therapist. I was just hearing before the talk about a program reaching out to music and art therapy here at UCLA and trying to extend those resources out. Those are the kind of things we involve into an interdisciplinary team, whether it be a dietitian and a patient who, many people with cancers of the stomach or in the colon may have a lot of difficulties with digestion, and dietitians can be incredibly helpful with helping define a regimen of what kind of breakfast, lunch, dinner is most helpful and helps avoid symptoms. Pharmacists, dentists, volunteers, these can all be part of an interdisciplinary team. And as a picture of that, it might look like this, with the patient and the family there at the center. Whether it be one or two of these pieces, maybe the home health aides along with the physicians, or it be the entire team, it's all about patient and family-centered care and provided by that team together. So some people may ask, well, how is this different from what's offered through the Sims-Mann UCLA Center for Integrative Oncology? And it's not. We work together. So some of our outpatient clinicians are here today, and we frequently are involving the Sims-Mann staff, the social workers, the chaplains, and their psychologists, and that's how we have put together our interdisciplinary team for patients with serious illness and in the setting of cancer. So we work together. You may often be seeing that same person. So that take-home mentions that palliative care is not end-of-life care. So kind of scratch that. It is also, but that is not the definition nor the base of it. It's about focusing, it's care focused on improving the quality of life for people with serious illness. So I want to share with you a study from 2011 looking at what are people with serious illnesses, what's their biggest concerns? And people had said that doctors might not provide all the treatment options or choices available. Doctors might not talk and share information with each other. Maybe they might not choose the best treatment option for a seriously ill patient's medical condition. These are a lot of fears. It sounds like a lot of fears about being heard or communication. Patients with serious illness and their families may leave a doctor's office or hospital feeling unsure about what they're supposed to do when they get home. And when people are overwhelmed with emotion, hearing about how their life is changing, whether it be with a new diagnosis or just going through the day-to-day life and the stresses of illness, it's easy to forget even if someone spent the time going over some material with you. And patients with serious illness and their families don't have enough control over their treatment options. Uncertainty and control are things that are really big issues when people are going through serious illness. And concerns that doctors don't spend enough time talking with and listening to patients and their families. Anyone nod if this sounds consistent with concerns either you or your loved ones have had? A lot of nodding, yeah. So a real challenge here is along with these concerns, there's a lot of mismatched care for people with serious illness. Some people may receive care they don't want and can't benefit from. And people may not receive care that they do want but could benefit from. Things like pain control, that many people are wanting pain control at any stage of illness, and maybe it's inadequate pain control they're experiencing. So again, what does palliative care do? So that comes from asking the questions of, well, what do people with serious illness want? That's where this field developed out of, is tending to the needs of those with serious illness. So what do they need from the healthcare system to make their life better? And in addition to us kind of knowing this, it's also been studied. So from Steinhauser and Singer from 2000 and 1999, people want relief of pain and other symptoms. People want communication about their illness, their treatment, and help with making decisions. And they want support. They want emotional, they want psychological, they want spiritual support, and they want practical support. What do I do next? So who should get palliative care? Well, anyone with serious illness, and serious illness is often life-threatening. So these are the top leading causes of death in the United States and the developed world: heart disease, cancer, chronic lung disease, stroke, dementia. Many people don't die of that disorder, but these are serious illnesses. And it happens at any age, any stage of serious illness, and in any setting. So it can be the clinic, it can be in the home for people that have difficulty getting to and from the clinic, or it can be in the hospital. So let's look a little bit at some of the symptoms. What symptoms can palliative care help with? So it's in general, if we're looking in the setting of cancer, we ask the question then, what are the common symptoms during cancer treatment? And these are the symptoms that palliative care can help with. Your oncologist is likely tending to these already, but again, this is an extra layer of support, someone else to assess and check in, or if those symptoms may be persisting despite those treatments. So common symptoms being pain, nausea, fatigue, appetite problems, low mood, anxiety or worry, breathing discomfort or cough, fever, sweats, hot flashes, constipation, diarrhea, dry mouth or taste changes, nighttime sleep problems, concentration, thinking, and memory problems. So a lot of different things, a lot of different symptoms that can occur in the setting of serious illness. So we're going to look at three of them, pain, nausea, and fatigue, a little more in detail, but let's just make sure we're clear on what is a symptom. So the subjective evidence of disease or physical disturbance observed by a patient. So symptoms are generally not observable by others, and they have to be reported. You have to say what they are for us as clinicians to be able to identify, assess, or act on these. So if you don't tell me that you have a symptom or that your loved one has a symptom, I don't know. Sometimes we can see a symptom, but the vast majority of the time, it's completely subjective and it's something that person experiences. And I don't know unless you tell me. Is that surprising to anybody? We kind of assume, oh, well, doesn't medicine know? Isn't that why they spent 10 years in school? Yeah. But yeah, we can't read minds, unfortunately, yet. But if you tell us, then we can help. So what causes symptoms during cancer treatment? The disease itself. The cancer could have a mass effect kind of pushing on a nerve, and that causes pain in the nerve, kind of swelling. It could be the treatments themselves, side effects of treatments. You can get tingling, numbness in the hands or feet from a number of therapies like the taxanes. Pre-existing disorders. People come in already with arthritis and have joint pains, can have symptoms, pain, or new non-cancer illnesses. Maybe someone kind of throws out their back and develops low back pain. All of these things can happen. So for example, looking at pain, as we were just talking about, what does that symptom come from? It's about incorporating the pathophysiology of the pain. What's the biology behind it? We don't kind of shotgun approach, just give pain medicines. We figure out where it's coming from and try to treat that. So if it's a tumor and an anti-tumor therapy can shrink that tumor or make that tumor go away, that's the right answer for making that pain better. Often even during treatment that causes swelling and there's pain associated. So it's normal to need pain medications or other therapies at the same time. Very normal to have symptoms and pain in the middle of therapy, and often it's a sign that therapy is working. Pain medications can range from Tylenol, Motrin, or ibuprofen. Those are those non-steroidal anti-inflammatories, to opioids like morphine, oxycodone. Those are the mainstay of severe pain treatment. And I just want to note not to be afraid of things like morphine and oxycodone. There's a lot in the news about of people dying or having side effects from these. When used appropriately, and when the symptom is there and we're treating that symptom with the medication appropriately, people do better when that pain is controlled. So people live longer, people do better with their therapies. It's important that if you have fears or concerns, let your clinician, let your physician or nurse practitioner know so you can discuss those and make sure to find out, is that a concern that we need to change therapy for? Or is that one that maybe it'll help if you get some education on, oh, that actually doesn't hurt me. That can really help me tolerate this chemotherapy I'm receiving and doing better. Anticonvulsants like gabapentin, I had mentioned people may get tingling or nerve-like pain, electrical pain in their fingers or in their feet. Gabapentin is a commonly used medicine for that kind of symptom. Or muscle relaxants. Often people get very tense or stressed from the pain itself. And there's also interventional therapies, nerve blocks, and our pain anesthesia colleagues are the ones that we turn to for those interventions. So if there's a specific pain, pancreatic cancer being a very common one where a nerve block around the area of cancer can actually relieve pain if it's getting very severe and we're starting to have to use higher doses of pain medications, and can be very effective at relieving symptoms and decreasing side effects that might happen from those medicines someone had to take. Physical therapy, if someone's weaker, or strength building would improve that background of pain. And also things like acupuncture, complementary and alternative medicines. Lastly, cognitive behavioral therapy has good evidence on a lot of pain syndromes. So there's many different layers and different things that can be personalized for each individual about what is the right way to treat their pain and what meets their goals. Where does their value system come from? So let's look at fatigue. A big picture point is a lot of people forget when they start a chemotherapy, for example, that they're used to having a certain amount of energy in the day. And suddenly your body is going through a lot of work to take that therapy and get better. And there's less energy you now have. So that's what's called energy conservation or self-pacing, is realizing that maybe during that therapy, you're not going to have the same amount of energy available. And if you know going out to dinner that night's where you really want to have, be alert and enjoy your time, you might want to be really taking it slow during the day so that you have that energy at nighttime. And so the idea of self-pacing is really important. Sleep hygiene, whether it be no TV, no reading in bed, trying not to take naps during the day, having regular bedtime and wake-up schedules. Psychostimulants, and we're going to look as an example at one of those from some of the literature. Things like methylphenidate or Ritalin and modafinil and Provigil can be helpful in the appropriate people. Blood transfusion. So if someone's feeling fatigued because their blood count is low, your oncologist will be measuring that, and if a transfusion is both appropriate medically and helping symptoms, can get that. That's what makes sense. And again, acupuncture shows up as something with evidence for being helpful in fatigue. So looking specifically at, I can't show you all the literature, but just to give you an example of some of the literature behind our decision making when we're looking at different therapies and individualizing them. So this is, methylphenidate is Ritalin, and that it is not effective for milder fatigue, but it can be for more severe. So in a study of 148 patients, they received either long-acting methylphenidate, Ritalin, or placebo, generally a sugar pill, for cancer-related fatigue. These patients overall didn't have an improvement in fatigue. So if we just take it at face value, don't give Ritalin. But when we look closer, there's a subset of patients with more severe fatigue, and also patients with more advanced cancer, that there was some fatigue improvement. So it's not the right answer for everybody, but it's the right answer for some people. For example, I took care of a woman who was having difficulty making it to her next cycle of chemotherapy. She was kind of losing confidence from how fatigued she was getting, difficult to get out of bed. Making it to lunch with her daughter was a challenge. And she was kind of getting low down on her mood, and a lot of this came from just the fatigue itself, a very common symptom. And she was receiving curative therapy, but it was difficult to go through. So we talked, and her fatigue was so severe, it was pretty hard to get out of bed. This made sense as something for her to try. So she used it as an as-needed medicine, and especially when she knew she was going to be going out to lunch, and when she wanted to do something specifically. And it really helped get her spirits up, feeling like she had a little more control over what was going on.
Would Adderall have some similar effects? Because I know those are the two medicines that are very similar. Did they do any studies on Adderall as well?
I don't have the extensive studies on Adderall. There are a few more on Ritalin specifically. So it's not that it's a wrong agent, but it may also have some of the similar effects. Yeah, good question. Just as a note, there are side effects with Ritalin use. So people, like you discussed with, mentioned Adderall, people get nervousness, may get appetite loss. So if those are side effects that don't make sense for that person, then maybe that's not the right medicine. But things need to be kind of tailored to what meets that person's goals, what's that person's specific life, what's happening on a day-to-day basis. How do we pick the right treatments for them? It's not unlike when your oncologist is, or your loved one's oncologist is choosing a cancer therapy. There's very rarely one cancer therapy that's right for one person, right? It's a person has cancer and it's choosing a therapy that's tailored to them that makes sense for their disease process and their situation. So it's about treating the person, and it's the same thing that we're doing when we're looking at symptom management. And looking at nausea. I think big point here, we'll go through some of the different examples, is that there's a lot of different therapies, and this is not the most exhaustive list. We even have more, these aren't effective. Zofran, the ondansetron, is a serotonin antagonist, 5-HT3 antagonist, and compazine, a phenothiazine under the dopamine antagonist, are probably some of the two most commonly used nausea medications. But things like Zyprexa have been restudied again as an anti-dopamine to be really effective in the setting of chemotherapy use for nausea. Neurokinin 1 inhibitors are now a standard therapy in very high nausea-inducing chemotherapies. Aprepitant is the name for that. Dronabinol, cannabinoid receptor agonist, can be effective in the right people. It can cause some sleepiness, sedation, a little confusion in higher doses, but for the right person, it can be the right medicine. As a note, so it's, think marijuana, except the Western medicine version of it in a pill form.
CBD.
Correct. So when we're looking at marijuana, just as another point, is that natural occurring marijuana and smoking that can actually be very effective, but just that it's can be quite hot, and so especially in people that have compromised immune systems, just being cautious that if you're singeing some of the airways, you might be having a higher risk actually causing some infection. Corticosteroids, things like dexamethasone, also commonly used in the setting of nausea along with chemotherapy. Acupuncture, very effective. So the take-home point here is many patients are reluctant to report side effects and symptoms to their doctors during treatment. But please tell us, there is no correlation between the number or intensity of treatment-related side effects and clinical outcome. When you treat symptoms, you do better. We need to know about them to help you do better and help your loved ones do better. So when in doubt, report symptoms, even if not asked. So what if we treat these symptoms and have these conversations? What if palliative care is involved as a consultant along with that care, and we're attending to these things in addition to your primary teams as kind of one large team together? So this was studied. In 2010, Jennifer Temmel at Mass General Hospital, along with her team, looked at early integrated palliative care from the time of diagnosis. This is a cancer clinic at Harvard, great institution. 151 people with a new diagnosis of incurable lung cancer went into this study, and everyone got the best standard oncology care. But half of them also got palliative care when they were diagnosed. So finding out the horrible news that you have incurable lung cancer, but being told, okay, now let's add this team to care and let's see what happens. So what do we think happened? Well, the answer is all good things. So there were better outcomes for people with early integrated palliative care. There's better quality of life, less depression, less pain, less nausea and shortness of breath. People were less likely to die in the ICU, and most people don't want to die there. Some people do. Everyone has a different preference about how they want the end of their life to look, but most people don't. And there was a longer life on an average of 2.7 months. So that's the part that surprised everybody. People weren't really expecting that. Wow. So that's as good as chemotherapy. So if that was a pill, someone would be making a lot of money off that right now. But this is people. This is how do we get a team of people together to help other people and to listen to them and to tend to their questions and to be that extra layer of support. And special note, there were no bad side effects from palliative care. Wow. So why wouldn't you want it, I guess is the question. But what are some of those, how does that conversation happen? I've been talking about matching treatments to goals. I just want to show you a slide that I show my medical students, that I show my colleagues. any conversation we had, whether it be the person I talked to you about from clinic that didn't want to take a simvastatin and instead wanted to take red rice yeast, which I can never quite say right, it's a tongue twister. Or it be someone that's deciding on a kind of complex set of therapies around their cancer. It's the same concept. The patient and the family, they're the ones that know their goals of care. I don't know their goals of care. Our medical team, what we know is what we've studied, which is we know what are reasonable medical treatment options. We know which chemotherapies could make sense in this setting. Does radiation make sense? Does giving morphine for that pain make sense? Should surgery be an option here? Is that going to be effective? But what are the values of that patient and family? What are their hopes? People aren't usually hoping for chemotherapy. What they're hoping for is what the chemotherapy allows them to do in their life, right? Does it let someone make it to their daughter's wedding? Does it help them to, maybe they're writing a book and they're working on a business and they want to get back to that? It's not about getting the chemotherapy, it's about that letting them live the life, their personhood, going through their life story the way they want. It's about living life the way we want to. And so matching treatment to goals is about matching what are those things that the medical care providers know are options, and making sure the patient family get to voice what really matters to them so we can come up with a plan of care together. And that's what it's all about. So I want to share with you some good news, and I want to share with you some bad news. So life expectancy continues to increase. From the Stone Ages and when people were living 20 to 30 years of age to modern sanitation bumping up that life expectancy significantly, antibiotics, modern medicine. If you had been to Dr. Hurwitz's lecture last month and hearing about the amazing therapies for breast cancer, and if you've ever heard Dr. Hecht here in the audience talking about some of the work he does, this is amazing work at extending people's lives. We can help people to live longer, and we can really often turn serious illness into either a chronic illness or cured, which might not have been cured before. That's amazing. But there's some bad news that we haven't been able to change the death rate. So we're all still gonna die. And maybe it's something we don't like thinking about, but it's also a blessing. It's thinking about what is the time that we have left and how do we want to spend that. You know, we make our mistakes and we learn from them. We have wonderful time with loved ones and family, and we get to experience that. What is the things that we want to do with the time that we have left? And that's different for each one of us. So I want to quote again Eric Cassell, physician and author. "The relief of suffering and the cure of disease must be seen as twin obligations of a medical profession that is truly dedicated to the care of the sick. Failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering itself." So as our medical interventions get more advanced and we're able to help people live longer, we need to make sure we're matching those interventions to people's goals, their values, their life stories. And if we don't, sometimes we can fail them. So that transitions us to conversations about the end of life and talking about our preferences at the end of life. And for some people, this is the norm. Maybe you had been to Dr. Wenger's talk and heard about advanced care planning, that this isn't about people with serious illness even. This is all of us should have this conversation. I've had this conversation with my parents. I've had this conversation with my wife. These are really, really important. And let me tell you why. People do better. It's good for both the people and their loved ones. And this has been studied. So in this study with 332 people in advanced cancer, they asked, have you and your doctor discussed any particular wishes you have about the care you would want to receive if you were dying? And 37%, about a third, had discussed their preferences with their doctor. And people who had a conversation, they weren't terrified, they weren't worried, they weren't sad, they weren't afraid. There was nothing different about these people who had these conversations. Can anyone guess what was different?
I would say acceptance.
Acceptance. Okay. I also want to know, none of these people were, it wasn't that they were older, they weren't sicker,
Greater sense of control.
that maybe they had greater sense of control. So these may be some of the outcomes, but what's interesting is did the doctor bring it up? That was the only thing that was different. And the doctor didn't bring it up more in someone who was sicker. They didn't bring it up more in someone who was older. It was specific clinics where doctors tended to just have these conversations more. In those clinics, it happened more often. So nothing to do with how sick someone was. And so what happened? People who had these conversations, less chance of dying in the ICU, where, again, most people don't want to be, but better quality of life before death, and less depression and grief for loved ones. Wow. So you can have a conversation and you help not only yourself, but your loved ones do better. I can't think of anything else in medicine that does that. Have a conversation. You may live longer, you may do better, and your loved ones do better too. Wow. But how do you get started? I mean, these conversations are kind of hard to have. So here's some of the things that, from our palliative care field, that we think about. Kinds of things we may ask people. So what brings you joy? And these are things that we can ask ourselves. I mean, these are kind of the heart of who are we as people. Where do I find my meaning? Where do I find joy? And when you think about the future, what do you hope for? And looking forward, what worries you the most? Maybe you're worried that a car payment's kind of going to be difficult, or maybe you're worried that it's just different for each person. Kind of what is it that's mattering to them, and how do we tend to those needs, and how does this matter to our loved ones? And unless we have these conversations, those around us don't know what we're hoping for, what matters to us, and what we're worried about, and how we want to tend to these things. So I want to bring up, we've been talking about palliative care and kind of where it happens, and this is the concurrent model of palliative care that along with curative intent therapy, palliative care is happening. So whether it be by the oncologist that's giving pain medicines, listening to you about and listening to your loved ones about what are you concerned about, what pain is happening, is there nausea, how is this affecting someone's life? I mean, these are big stressors, especially at diagnosis, whether it be someone with diabetes that suddenly has to change their lunch schedule to someone with cancer where suddenly they may not be able to work, and they're having to change their entire life around this illness and how they're going to treat it. So whether there's a specialist involved or not, people are tending to palliative care needs. And those may go up, they may go down. There might be more of the proportion is aimed at cure, more is aimed at symptom management and kind of listening to what kind of support is needed for their family. And at some point, we all die, and that's usually when hospice is available, around that time. And we're going to talk briefly about the difference between palliative care and hospice, and that's where bereavement care is there for the family members. About half of people in the country, based on AHPCO data, are utilizing hospice, which is a wonderful resource for people when it's right for them. So when is it right time for a palliative care referral? So maybe it's at diagnosis for some people, or maybe it's when symptoms are still disturbing daily life despite current therapies. Could be when treatment decisions are getting complex, and having an expert to talk through different options can ease that stress and that anxiety. It's different for everybody. Palliative care is not hospice. And I'm going to show you just a diagram to kind of help, because I know this is often a source of confusion, that all hospice is palliative care because they are receiving care that is aimed at the whole person, care that is for symptom management and support. And that's what palliative care is about. But palliative care has no relation to prognosis. What's different here is that hospice does have a relation to prognosis. So that's when someone has more than a 50% chance of dying in the next 6 months. We don't know they're going to, but more than a 50% chance. And so those services become available for people when that prognosis is present. And it has a specific funding mechanism. And it can be done in the home, it can be done at living facilities, it can be done, and in certain cases in the hospital when appropriate. It's all that extra layer of support, 24/7 access to palliative care experts to be able to answer questions about symptom management, but they're different. I want to mention prognosis. Oh, sorry, assisted living facility. So prognosis is really difficult for a lot of reasons. In general, people want to know. I'll bet we generally want to know with a bit of optimism, but we want to know. Different people want to hear it in different ways, but it's really difficult to estimate, and doctors really don't like to discuss it. It often makes us uncomfortable to talk about it. But without that information, people assume. I was recently taking care of someone in the hospital who had some laboratory tests that had come back, and they were a lot worse than they were before. And he had heard about the laboratory tests, but he hadn't heard about what his prognosis was. And when we brought that up and asked him what he was thinking, what he was kind of thinking about for the future, and asked him what his understanding was of what was going on, he said he thought he only had a few days to live and he was expecting to die in the hospital. It turned out he was actually quite wrong. Those tests were suggesting he had more like around months or so, likely less than a year. That really kind of changed. He kind of got really bright and realized he had a lot more time to spend how he wanted. And it really kind of drives that point home that people really can assume if they're not hearing, at least some degree of estimation. So if you're not told, you can ask, and you can ask for ranges. Doctors may say, I don't have a crystal ball, and that's true. They don't have a crystal ball, but we're pretty good at ranges, whether it be days to weeks, weeks to months, months to years, or years. And really if we knew that we only had a year to live, wouldn't we all live our lives a little bit differently? I know most of us would. And prognosis is about opportunity. It's knowing if you have that time, whether it be more or less time than you were expecting, it's how are you going to spend that? How do you choose to spend the time that you do have? It's about priorities. Maybe it's about closure if there's less time than what was expected. About being able to say the things that are important to say to loved ones and family. And it's about hope. Whether it be hope for cure, whether it be hope for getting back to the function that we had before. For everyone, that hope is different. We'll talk a little bit about hope. That it can be for healing in that face of serious illness and uncertainty. And uncertainty is, especially with a lot of our new therapies, has become an even bigger deal. People that previously might have been completely appropriate for hospice, we're seeing receive immunotherapies and not need hospice for a very long time. It's another illness that they get decades down the road. Things have really changed in the face of recent advances in oncology. But it's also hoping for healing when there's not a cure. Finding that balance, having those conversations with our loved ones in ways that close things the ways that we want to, and having some control over that. And it's about comfort. We talked about suffering. It's about attending to and relieving suffering. It's about all that's possible despite what's not. And hope is enduring. So I was recently taking care of a person in the hospital, and this woman, there was so much she still had that she was hoping for. It was amazing to hear the brightness and all that she had to share. And it's a reminder that hope is there even when people are at the end of life. But it should be there always. Not having hope is often a sign of depression. If we're not seeing hope, whether it be getting curative therapy or it be at the end of life, that is a concern. And depression is not normal and it responds to treatment. People get better with treatment. So discussing prognosis does not displace this hope. It gives us opportunities and a lot of times it gives us hope. In summary, palliative care is for people with serious illness. It's care that helps people live with the best quality of life for as long as possible and to live longer. It's about, remember to report symptoms, just as a note, even if not asked, that suffering can be attended to and that people do better when symptoms are brought up and when they're treated. Bless you. And that conversations about end-of-life preferences are good for people and their loved ones. And palliative care is personal, and it's different for everyone. So this is what our palliative care program looks like here. Things have changed a lot in the last 5 or 6 years, and we have inpatient palliative care services at both of our hospitals. We have a comfort care bed for people at the end of their lives at the Santa Monica Hospital. We have a service integrated with the advanced heart failure service to treat symptoms, to provide support, to help people do better. We have integrated and freestanding palliative care clinics. Sarah D'Ambrosio and Dr. Weiss are here today from some of our outpatient clinics. And again, we collaborate with SIMSMAN to provide these outpatient psychosocial and spiritual support. And we have home palliative care services for people that it's difficult to come to the hospital, or that it's difficult to come to the clinic. We have a nurse practitioner and physician that are able to visit in the home, and it's generally a nurse practitioner run service. And we have a homeless outreach and advanced care planning. And in education, we have a fellowship program. We have electives for our medical students. We have nursing curricula, and there's ongoing research. How do we do this care better? How do we continue to help people live their lives better and live longer? And for anyone that, again, I think these slides are all available online, I just want to put this up there. Information can be dangerous, and I wanted to make sure you had access to what are some good resources. So the National Comprehensive Cancer Network, Supportive Care for Oncology guidelines. These are all safe websites that will provide you information that you can trust. American Cancer Society Patient Portal, the National Cancer Institute, the Cochrane Collaborative, and the Center to Advance Palliative Care. I'll let you finish taking some pictures. Great. And that's it. I have a lot of people to thank, and I can't fit them all on this slide, but and to all of you, thank you so much for coming. What do insurance companies say about palliative care? There's a growing support for palliative care. And since Medi-Cal recently put into effect that all patients receiving cancer therapy need to have access to palliative care, we're receiving even more support. We're even working with certain insurance companies to find out how can we better integrate palliative care into the clinics, because they see patients doing better and they want to support that and know that we spend a lot of time with patients, and sometimes it's hard to support that from a dollar perspective, and they want to help patients get best care possible. So we're working out creative ways, and the insurance companies we're seeing are very supportive of that.
I mean, would you say most insurance policies cover some level of palliative care?
Yes. Most insurance policies do cover some level of palliative care. I'd actually, to follow that up, I'd say what's more difficult is there's not enough of us that have been trained. So there's actually not enough access to the clinicians and the teams. So the insurances like it, the health systems like it, the patients like it, but there's not yet enough of us. So especially as you're leaving some of the cities, you'll find especially home palliative care services become very rare. And getting clinic-based palliative care services can be very difficult in a lot of places too. We're pretty lucky here at UCLA to have a lot of access to outpatient and home palliative care at this time. We have a lot of support both from the university, and it's really wonderful to see.
You haven't mentioned anything about the effect of California's new law on making decisions in advance. For a few of us, you don't want to be in a rush against time for the last 2 months available. Essentially, getting doctors, the 2 doctors necessary to sign up, or if you want to choose your own way of dying, and things like that. I would assume that palliative care, some of us would feel better knowing that you've made taking those steps in advance, and we can still get on with the hope and better quality of life, but we won't have that issue hanging over us, that if the worst occurs, that we are prepared for that last 60 days to choose our own way of dying.
So if I could restate the question and let me know if I got it right. That you're asking about how does the End of Life Option Act and the ability to take medications to allow someone to die without having to continue with their illness, how does that relate to palliative care? Is that a good way of restating it?
Right.
Okay. We, in palliative care and what's going on with the End of Life Option Act, end up being integrally related because these are people with suffering. These are people with serious illness and they're suffering. And they want an option to be able to allow death if they so choose. What we have seen at UCLA is that universally, and Dr. Coscarelli can also speak to this if that's helpful, but universally palliative care has been involved with these situations because there's 100% of the time been pain, other symptoms, and people have questions and suffering and have requested for a specialist to be involved. It's not required. So in answer to the question, palliative care is not required to go through the process of using the End of Life Option Act. Someone can do that if they have no active suffering and they have no questions for palliative care and don't feel they need to see a specialist. But what we've seen as this has started since this last year is that 100% of the people have asked to have palliative care involved. And the system has accommodated that. So yes, it ends up being related, but it's not that you must see a palliative care practitioner in order to go through that. That answer your question? Okay.
I have a question that I want to ask, which is a very delicate issue in my home, and only because I'm not the one that's suffering with the condition. It's my wife, and she's going through chemo and suffering some of the nausea effects and the lack of eating and so forth. And with the Zofran and the regular medications that the doctors prescribe, it helps, but it really doesn't resolve those issues. So I have a more of an open mind to alternative issues, and so I'm wondering through the palliative care program, if there are any specialists or have they done any research into what benefits can be derived through the use of, say, cannabis and so forth.
So it sounds like your question is that you have a loved one that is undergoing therapy for cancer and is having a lot of nausea side effects. They're on Zofran and other medications, but still having symptoms. And you're wondering if things like cannabis would be effective and what might make sense next. I guess I'd ask is, what do you think about involving a palliative care specialist? Be seen in clinic and have your loved one be able to spend some time with someone.
We plan on doing that.
Wonderful.
But how much knowledge or training or research would that person have in being able to appropriately prescribe the particular cannabis product that would be best suited for their condition?
So if you're asking, so the question is, it sounds like you have you've set up for your loved one a future appointment with palliative care, but you're wondering, does that specialist have more knowledge about cannabis in particular? And I'd like to back up and say that often cannabis isn't the right answer for people. And if a provider in a palliative care clinic doesn't feel they know as much about cannabis and they think it's the right medication, they will reach out to their colleagues. And we have specific colleagues here at UCLA. I know myself, I'd say I'm moderately well educated about cannabis in particular, but I reach out to a colleague of mine who is one of the nation's experts in the appropriate use of cannabis if I have questions. So what I would say is that I think if you're going to a palliative care provider, that's the right provider. And if they don't know enough and want some information, they will have access to the right people to get the right answers. And if afterward you'd like to ask, I can actually refer you to some of the specific experts in cannabis. But backing up is, again, there's often many other treatments that have less side effects and can better treat nausea before needing to use cannabis.
Although one of the advantages of cannabis is that you basically cannot kill yourself with it.
So the question is one of the advantages of cannabis that you cannot kill yourself with it? It's true, that is not a known side effect of cannabis.
It's very easy to kill yourself with oxycontin.
Correct. So using other medications inappropriately and not by the direction of the physician can lead to death in a lot of cases, and with many things we do. And it's true that with cannabis it's very difficult to do so and possibly impossible. However, I just want to note that the reason I say cannabis is often not the right, even as a second or third line, is it often causes a lot of confusion. And in terms of my personal recommendations is anyone over the age of 50, I kind of put it a little lower down the list because I've seen so much confusion. Unless someone has already been using cannabis, then they're usually a little more tolerant to it and may have less of those side effects. But when people start for the first time, around that age group, I don't have perfect evidence for this. This is just clinical experience. I've seen a lot more confusion happening when we try to titrate up on cannabis as one of the earlier agents. So I'll try other things first, and then we usually end up on cannabis as one of the later agents. As a side note, I was talking to one of our nation's experts in cannabis use for nausea in the setting of chemotherapy, and he really felt that smoking cannabis might be the most effective way of reaching just the right amount of control, because it has such a quick action of comes on very quickly and comes off a bit quicker. It's easier to find just the right amount of nausea control without overdoing it. So people can kind of do that. And again, trying not to do it with hot smoke is preferable because that can have its own side effects, but it might help some people to find just the right amount without reaching those levels of confusion. And when I refer to the confusion, it's more often with the pill form that we're seeing.
I just have a follow-up to that. Oh, I'm sorry, go ahead.
No.
I was just gonna ask you with regard to, the smoking of it. Back in the early 80s, late 70s, the cannabis that was around had a THC level of anywhere from 1% to 2%. But they have so modified it and refined it that nowadays, cannabis is ranging between 25 to 50% THC. So for someone who wants to smoke it, I don't even know where you could go to find the cannabis that has the lower amount of THC that won't cause the psychomatic effects that marijuana normally causes.
Was that a rhetorical question or a question? I'm going to take it as a rhetorical, if that's okay.
No, I'm
Or
just saying, for those patients that you're recommending smoking it as a way of being able to relieve the nausea, obviously the amount of THC that's in that particular cannabis, you would recommend for them to most likely smoke something with a much lower dose of THC, correct?
So the question is about what formulation of marijuana to use, and you're getting into very specific clinical questions, and I'd like to defer that to, if someone wants to discuss that during a clinic visit, I think it'll probably end up being more of the appropriate place, because it'll get kind of detailed. Yeah. Please.
Do I need a referral for my oncologist to contact the palliative care team?
The answer is, or the question is, do I need to get a referral from my oncologist to see the palliative care team? The answer is, yes, you need a referral either from your oncologist or your primary care doctor in order to see the palliative care team. So we are like any other specialist where we need a referral in order to see the patient.
And would this team work with my oncologist
And
to
the,
discuss, to understand the symptoms that I am trying to solve?
the follow-up question is, does this team, the palliative care team, work with the oncologist to help understand the symptoms and treatments that someone is undergoing? And that's the perfect question, and the answer is yes, of course. That is part of our purpose, is how can we help and be an extra layer if someone has further questions after they're discussing with their oncologist and wants to review more about their symptoms, wants to review more about the treatment they're doing and maybe some of the side effects related, or maybe they don't understand the treatment, we can help talk it over and then help a person bring that back to their oncologist and help reframe some of the questions that maybe they weren't understanding the answers to. The answer is definitely. It's exactly how we can be helpful.
Are there instances where palliative care continues beyond the end of medical care? For example, cancer treatment ends, is palliative care continuing?
So the question is, after cancer therapy ends, does palliative care continue? So let me ask a follow-up question to clarify. Are we asking if cancer care stops because it's ineffective and someone is dying? Or are we asking if cancer care stops and someone's doing either well or simply doesn't want to continue more, can they keep seeing a palliative care doctor? Okay, so it's the second, which is if cancer therapy ends, someone is either doing well or simply doesn't want to continue further therapy, can they continue to follow with their palliative care provider? And the answer is yes. We work with people with serious illness, no matter what their choices are, whether it to be continuing curative therapy, to do therapies that are only aimed at symptoms, or if they don't want any Western medical treatments at all. We are happy to be involved and see how we can help. We are specifically involved with people with serious illness. You might ask, well, if people are doing so much better with these kind of consultations, why isn't it there for everybody? What happens if someone comes in and there's just a lot of complicated dynamics and other pain and there's no serious or life-threatening illness? That's a bit of a debate in our field. And a lot of it comes down to resources. We wish we could be there for everyone, but we simply can't. And we want to make sure we're there for the people that most likely will benefit most from our care, and kind of aiming at somewhere where our evidence is for we're likely to help people the most. So if someone's stopping their cancer therapy and they still have a serious illness, palliative care will still stay involved and still be helpful.
On the acupuncturist, and I was curious that most of the public, the patients are exposed to the various types of the alternative therapies, and most of the alternative medicines are kind of very less likely, like a research, the less evidence-based. I was wondering if the patient asked about the some certain types of the alternative therapies. Do you offer the consultation about those therapies or the referral to the other therapies?
So the question is, a lot of people are aware of the evidence base for acupuncture, but not necessarily about other therapies. What happens if people are interested in other therapies? Do we either provide consultation or refer to them? And the answer is yes. So we have an East-West Medicine Center here at UCLA, and I frequently, when asked about what other therapies are available, bring that up as an option. And they are our experts for both acupuncture and access to other complementary and alternative therapies. And we have many people that we see that ask about these things, and we talk to our colleagues and place a referral for them to be able to be seen in those clinics.
Is patients and caretakers are aware of what's going on recently, where the FDA looks like it will be under increased pressure from the new administration and also the business of medicine to accept new treatments with very little of the past emphasis. Emphasis being on phase 1, phase 2, and phase 3 testing, where individual drugs may be good as individual drugs, and then the request to combine two individual drugs are not carefully measured as far as side effects. We can go to them for advice when this process seems to be headed to go to with the FDA's outstanding efforts to protect all of us seem now to be going to be watered down.
Right, so I'm going to restate the question and tell me if I get it about right, which is that there's concern with the incoming administration. Will there be any changes that we should be worried about as people receiving medical care, that there will be less robust medical studies on therapies in the future, and that we may not be able to trust those therapies? And the answer is, I'd say that talking with many of my colleagues about the incoming administration, which is very hard to predict what we can expect, we can say we are very independent from that, and I would not worry about medical science changing its practice for the incoming administration. I think you can expect us to be living up to our own highest standards that we can.